So I'm Maria Cavasin. I'm the manager of the Pre-Clinical Cardiovascular Core within the cardiology department. We had this fancy name that we decided to put a few years ago, but I think everybody knows us as the Ultrasound Core. So our mission is to collaborate with research groups across the campus and facilitate ultrasound imaging and analysis on their animal models of cardiovascular, pulmonary, renal, metabolic, and oncologic diseases. We also offer a variety of surgeries and more than 25 years of in vivo research experience. So if you are ready to move your research from bench to in vivo, we are here also to help you. We started with Tim McKenzie in 2010, where we were hired by Peter Badrick here, and we started our lab. At the time, we had a visual sonic ultrasound, and the model was Vivo 770. We used that equipment before in Gilead and Myogen. So we're coming from the industry. That instrument here was poorly organized, and it was not accessible to people or researchers in the campus. So that was our goal, to make it, to form the core and make it accessible. Our work in the lab and clients grew, and so in 2014, we submitted a shared instrument grant to purchase the Vivo 2100. At that time was the newer model of ultrasound in visual sonics. We have now two 2100. One was purchased with a grant, the other one was trade-in. We made a deal with the company. One of them is fully loaded, so it has pretty much all the features that you could have in this machine. The other one is basic. This model will be obsolete next year and will now be longer serviced by Visual Sonics. So this year we submitted another shared instrument grant, and for the newest model that will be released next year, which is called F2. So we jump 2 models here. In between is 3100. I believe we got a pretty good score, but we still don't know if we're gonna get it, but that's not a problem. We still can do all we need to do with these instruments. The F2 is just a smaller model, more faster in the software and a little more accurate in the imaging. So this is how it looks like. It's pretty bulky, it's a big machine. The Vivo platform was developed by Visual Sonics, but now was acquired by Fujifilm, and is the world's first commercially available high-frequency array-based ultrasound imaging for small animals. So it's considered the gold standard for in vivo imaging in a small animal. So what is nice with the ultrasound is that since it's not invasive, you could image the same animal over time, and you could do serial measurements of whatever you need to do. So basically, the core has 2 parts, the ultrasound, and also we offer surgeries, survival surgeries. So briefly, most of the presentation will be on the ultrasound, but we can talk later if you need any specific surgeries. The ultrasound and what we expertise, we have our expertise is cardiac imaging and assessment of the cardiac function. But we can also do 3D imaging, and that's very useful for tumor imaging, and you can serially assess the growth of the shrinking of your tumor. Why this jump? We also can image vasculature in of the big vessels like aorta, renal, arteries. Then we can do ultrasound guided injections. I've done in the past some studies where I can inject cancer cells, tumor cells in the heart or in the liver or pancreas. This machine also offer contrast imaging, and that's especially useful for to visualize organ vascularization. On the surgeries that we currently do is mostly for cardiovascular diseases models, thoracic aorta constriction, also known as TAC, left anterior coronary artery ligation to induce myocardial infarction. That this can be done with permanent ligation or ischemia reperfusion, where the ligation is untied and the blood flow is restored. And that's especially useful to mimic what happens in the clinic with patients. We also do nephrectomy. It could be unilateral nephrectomy or 5/6. This is our models of hypertension that will later cause cardiac dysfunction. And we can do also pulmonary artery ligation for induction of pulmonary hypertension. These are examples of images of the heart. So this is the left ventricle view in the long axis. This is on the left a normal heart, and this was a heart with coronary artery ligation. After 2 weeks, we can see that the walls are thinner and the chamber balloon, like enlarged. To measure the wall thickness and assess cardiac function, we need to put the transducer perpendicular to the long axis. So we call it short axis. So here we can see papillary muscles. So at the level of papillary muscles and the biggest diameter of the left ventricle, we do some measurements. So now the heart is viewed in a plane, and we can measure wall thickness. So this is the anterior wall, this is the posterior wall, this is the chamber. So when we measure at systole and diastole several times in a cycle, we can estimate the ejection fraction, shortening fraction, and that's the pumping of the contraction of the heart. Here is the same example and short axis of a normal heart and a heart with myocardial infarction. As you can see, the heart is much larger. So when we measure this, this was one of our studies, and we compile the data. So we can see that after 2 weeks in the infarcted hearts, the LV internal diameter is higher, and this translates in a poorer function or contractility. This was just one point, but we could do it serially, and I'll show you that. We also can assess diastolic dysfunction. That is the relaxation phase of the cardiac cycle. I'm not going to go to the very details. So in general, we visualize the heart through the apex, and we can see the 4 chambers. So to assess diastolic dysfunction, what we use is the mitral valve imaging or itself as a tissue Doppler, or the blood flow through the mitral valve. So in diastole, we get two waves that we call E and A, because the diastole phase has two parts. But anyway, in a normal heart, the ratio of these two peaks, E divided A, is close to 1.5. And that also occurs in with this E prime A prime ratio, which is the mitral valve movement. So this is the blood flow through the valve, and this is the movement of the valve. Both of these numbers are in normal hearts are close to 1.5. This is an actual study. It was published last year, and we serially measured EA and E prime A prime, and we use a model of hypertension here, and it's our best model that we know after a few weeks hypertension can cause cardiac hypertrophy, and that is translated to diastolic dysfunction. Here are examples of the waves E and A and E prime A prime. So over time, sham mice, normal mice, non-diseased mice, have around 1.5 of these ratios. The model is called DOCA. So these are hypertensive mice that got sick, and over time, this ratio decreases, and is close to 1. Then with our intervention, and this is what we use here is an HDAC inhibitor, we could recover diastolic dysfunction. This is just to show you that with ultrasound, you could have powerful longitudinal studies. So measure same thing over time. And this is very useful for your animal research. Another feature that the ultrasound has is called Speckle Tracking. Hope this works here. And what this does is generates vectors of forces. It shows the force in a particular portion of the myocardium. So this is the short axis, and this is the long axis. The ultrasound machine has a software to translate this in numbers, but it's a little complicated. I hope in the new version they improve these calculations of what we can get out of this. But it's particularly useful in myocardial infarction models, so where you can see over time if you have deterioration of the contractile force, or if you intervene with any drug compound, you could also assess the improvement. We can also see pulmonary artery flow, and this is particularly useful for pulmonary hypertension models. We also have paper with this. Basically, we put the transducer very close to the pulmonary valve, and we can see the flow. So this is a normal flow peak. When the animals get pulmonary hypertension, the peak tends to decrease, and also in severe cases, we see this notch. This is a real study that we performed a few years ago using the Sugen hypoxia model. So here is the normal flow through the pulmonary artery. Then when the animals get sick, we can see the notch, and here we don't have actual numbers, but the peak is also shorter. And in animals that receive just vehicle, these keep progressing. But then we intervene at 3 weeks with a combination of ambrisentan and tadalafil, and we actually could rescue and make make them better in their pulmonary flow. We can also visualize RV wall thickness, and that's also a very common assessment in pulmonary hypertension studies. What I get from some people is they ask if we can measure ejection fraction in the right ventricle, and that's not possible, and it's not accurate, although some people publish it. But as I mentioned in the LVE, we have the papillary muscles as a landmark to place our transducer consistently in about the same place in all the animals. The RV doesn't have papillary muscles or anything that we can use as a standardization of our images. So what we can get is right ventricle output, cardiac output. These are now examples of vascular flow, and what we can do with this. This machine has color Dopplers, so you will see on red blood that is coming toward the transducer, and in blue blood is going away from the transducer. And what we normally you can do with this is to get the peak. This is a renal artery, so the highest peak and the lowest flow, and that with the formula you could calculate vascular resistance. So we had also some studies in uterine artery for some groups. So this is how the blood flow progresses in same animal in different gestational days. This is a femoral artery. This was study that we were asked to occlude the femoral artery and then see how long we take to restore the flow. So this is before occlusion, this is during occlusion. This is just an examples of things we can do. This equipment also can do 3D, and this is very useful for tumor cancer research or tumor growth. This is a subcutaneous tumor that we just had to image for a researcher, and then the machine has some tools to calculate the volume. So this is how it looks like. I'm not going to go over the software or the calculation. We also can do contrast imaging, and for this you need to inject microbubbles in the blood flow. So usually you could do a tail vein injection, and this is used by some other groups here. We don't do it, we just help with the imaging if they need it. So you could inject this micromarker with whatever antibody you wanted to visualize. For example, if you want to visualize just the vascularization of an organ, you will have antibodies for VEGF or VCAM. So these are examples of the pictures that you can get. And I just borrowed this from somebody's because it's not our studies. But for example, this is the kidney, or you can visualize a tumor also. And this is very useful for biomarker research, where you can modify the microbubble and insert any antibody that you want to have to go to your particular cell or structure to visualize. So basically, for the ultrasound, we have two ways of offer the service. We have two technicians, full-time technicians. So we could do your imaging and your analysis for a fee, or if we have some PIs that are familiar with this equipment and they want to do it by themselves. So we may just make sure that everybody is trained. So the ultrasound has the anesthesia machine in the same platform. So we use isoflurane, very light. So that not is 1.5. So that doesn't compromise the animal, and they recover really quickly. Hemodynamics are not altered with this percentage of isoflurane. So we could offer either way, our service directly with our time and our technicians, or you just rent time on the machine. We are in a new room, in the new hallway rooms that were just built between RC2 and the new research building, and our room is 506. I just want to point out that if you are ready to do animal studies with ultrasound or surgeries, and if you need to just have preliminary data for grants submission or have a pilot study, see how all these work, we could do it for free, no problem. Then once you establish your experiments and your designs, and we need to get together again and make sure you budget for these studies appropriately in your brand. So we have a website too, and I don't know if you can just copy or Google it, maybe, yeah. And my PI is Tim McKenzie, but I mostly arrange all our calendars with our studies or the requested studies. And we have, these are our two technicians, Elizabeth and Saban. Okay, that's all I have for you. Thank you very much. And just contact me for any questions on pricing or scheduling.